Welcome, everybody. So today we've got with us Dr. Rachel Teranishi. She is an assistant professor in our Department of PM&R. Prior to joining our department, she completed her PM&R residency at Stanford University and a brain injury medicine fellowship at Carolinas Rehab in Charlotte. Throughout her residency and fellowship training, she completed several rotations at VA hospitals, which stimulated an interest in the military population as it pertains to brain injury. Additionally, she was a recipient of the UAB Patient Experience Excellence Award in 2023. So please join me in welcoming Dr. Teranishi as she discusses traumatic brain injury in the military population.
All right, thank you, everyone. So we're having a little bit of sound difficulties, so I have to stay close to the computer so people virtually can hear me. And I did have a video clip, but we'll kind of just all narrate through the scene so you guys can imagine what's going on. So thank you for the introduction. Thank you for being here. Like Dr. Hollis said, today I'll be talking about traumatic brain injury in the military population. And I have nothing financial, no other conflicts of interest to disclose, but my only disclosure is my civilian status. So obviously I have more of an external perspective when it comes to all of this. But as Dr. Hollis mentioned, I did a lot of my rotations at the VA during my residency. Almost half of my rotations were actually at our VA doing both inpatient and outpatient. And during my fellowship, I also had a really unique opportunity to do an outpatient TBI rotation with one of the doctors over at the VA in Salisbury, which is about an hour north of Charlotte. And something that's probably true for many of you. I know a lot of people who have served, in particular for me, my grandfather, he was in the United States Army during World War II, was a recipient of a Purple Heart. So for all these reasons, this population is really near and dear to me. And so I'm excited to be able to talk to you guys about it today. So this is an introduction of what I'll just be going over in the outline. So I'll start off with just some brief information about what military TBI kind of looks like. And then we'll also spend some time talking about deployment, because I think it's really important to understand the context in which these individuals get their brain injury. We'll also talk about some of the different injury types that you can see in the military. Particularly, we're going to be focusing on blast injury because that's a little bit more specific to that population. And then we'll go over some of the comorbid conditions, really emphasizing PTSD just because of how prevalent it is in this population. And I have a few studies just kind of to mention the different research that has been done over the years. Obviously, the military history is huge over many, many years, but it wasn't really until more recently, 2001 and onwards, that there was a lot more interest in and recognition of TBI. And so a lot of the information from this presentation will really be around that time period. And so just some abbreviations for you guys to know, just in case you're not aware of, they'll kind of come up in some of the slides. OIF is Operation Iraqi Freedom, OND is Operation New Dawn, and OEF is Operation Enduring Freedom. And these are the three big military campaigns that were going on during this time, starting 2001. Okay, so between 2000 and 2019, there were over 400,000 individuals diagnosed with at least one TBI. And you probably have heard the phrase TBI is one of the hallmark injuries from this time period, and that's because there were just so many individuals who had a TBI. One study found that of all the injuries during this time period, about half of them included the head and neck. So it's something that came up quite a bit. This is the breakdown of the severity for those 400,000 individuals. And as you can see, very similar to the civilian population, overwhelming are still going to be mild TBI, followed by moderate, and then smaller numbers of severe and penetrating, and then a few that weren't classifiable. As you can imagine, TBI is going to be more common in the active duty reservists compared to the civilian population. And a lot of them get their injuries obviously during combat, but it's important to remember that there are other settings that they get them. When I was doing my residency training, a lot of them were in combat exercises when they were on base. Some of them are just like regular life things that happens. You fall, you're in a car accident on base. That's still kind of incorporated into military TBI. And the main mechanisms, again, we'll talk about blasts a little bit more later in the presentation. Falls, car accidents, and gunshots are going to be the main reasons for their injury. This slide is about the healthcare utilization among OIF, OEF, ONG veterans, and it's just to show what people are kind of seeking care for. So of those 3 military campaigns, about 2.7 million people served. And then of those, 2 million were eligible for VA benefits. VA has kind of different criteria for if you're eligible for their health benefits. So of that group, about 2 million. Of those 2 million, about 62% sought care. Most of them are going to be in the outpatient clinic setting, followed by a little bit in the inpatient setting. And the graphs there are just the main reasons why they're going to the doctor. I'm not sure if everybody can see it, but MSK, neurological, and mental health disorders are the really big categories. And then there's also this ill-defined category, which is actually 160 different subcategories. And its main characteristic are signs and symptoms that at the time of the clinic visit don't have an obvious cause. And so a lot of those subcategories are respiratory illnesses or symptoms, but a lot of them are head and neck symptoms. And so a lot of the TBI patients really fall into that ill-defined category as well. So I wanted to show this slide for a couple reasons. One, just to see why these people are going to the doctor. And two, to point out that we're still missing a huge proportion of people, right? So almost 3 million serve, 2 million are eligible, only 62% seek care. So you're still missing about 1.5 million people. So we really don't know much about those people. They're not really included in these slides. So just kind of keeping that in mind when you're thinking about military TBI, there's a big chunk of people that we're missing. Next, I'll talk a little bit about deployment. Like I said, just to appreciate the setting and the context when these people get injured. Think about a lot how, you know, 2 people with very similar injury patterns will recover completely differently. Certainly there's lots of reasons for that, but I think kind of the state of your brain when you get your injury probably has some impact on that. And so in terms of deployment, these individuals are under extreme stress for days, weeks, months, and then they get a brain injury. They're sleep deprived, they're dehydrated, they're under extreme physical and psychological stress, and then they have an injury. So there have been a few studies looking at what are the consequences of deployment just by itself, outside of TBI, outside of any injury, what happens when you're deployed. And so the Millennium Cohort Study looked at almost 80,000 people who were deployed, and they found that they were much more likely to report physical symptoms at multiple time points. There was another study that did a post-deployment assessment. So at the time that they were deployed and then 6 months later, and these people were much more likely to report mental health issues. So both physical and mental health is affected with deployment. Probably not surprising, but it's nice to kind of see the data supporting what we think is happening. This study took it a little bit further, and they actually did neuropsych testing for people who were deployed. So it was about 1,000 men and women, and there were 2 groups, one that was deployed and then another group of matched non-deployed controls. And so they actually did neuropsych testing on these people before and after they were deployed, and they found significant differences between the 2 groups, specifically in attention, verbal memory, and visuospatial learning. So between whether you were deployed or not made a difference. When they looked at those 2 groups, obviously injury rates were higher in those who were deployed, and so that certainly plays a factor into those things. But when they looked at all the different characteristics and they controlled for that, it did not explain for all the differences they saw. So the authors really concluded that deployment alone, outside of injury, can actually have impact on your cognitive functioning. And they kind of looked into why they thought this was. And one of the reasons is I think when you're deployed, you're just survival instinct. That's how your brain is kind of wired. And so maybe over time, you have like less attention and memory for non-life-threatening things. So when you're going to do a neuropsych testing, it's not a life or death matter. And so perhaps, you know, that's why you're testing differently. And then when they talk to the individuals in the study, you know, they're reporting things like they saw their friends or innocent people get injured or killed, seeing homes destroyed, people begging for food. So being exposed to a lot of trauma. So it makes sense that there are going to be impacts from that. So now we'll move on to talking about blast injury. So as I alluded to, blast injury has become just so much more common with modern warfare, not just TBIs, but other types of injuries. And so there have been a couple of studies looking at how common blast injuries are. And two that I listed there, they reported anywhere from 88 to 97% of all injuries that were treated at medical units are from blasts. So it's definitely happening a lot. Another thing I mentioned in the beginning is that, it wasn't until more recently that there was more interest and recognition of brain injury. And so before that, there were lots of different names for brain injury, particularly mild TBI. So things like commotio cerebri, shell shock. And so as you can imagine, if you can't even call it what it is, it's going to be really hard to sort of standardize treatment, screen and assess and do different things like that. And before there was more of a standardization, there was a lot of variety in clinical practice and how early these people returned to active duty. One study found that on average, people returned just 3 days after their blast injury. Again, that was prior. Since then, there's been lots of research efforts to improve this process. In early 2000s, the VA kind of called this expert consensus group of both military and civilian individuals, and they came up with their own standardized guidelines for mild TBI. So now they have something called the MACE, which is Military Acute Concussion Evaluation. And so it's much more standardized now. So this is all kind of old practice, and they've made a lot of efforts to kind of improve the screening and treatment for these people. When you think about blast injury, or I'm talking a lot about blast injury, and it's interesting because there isn't a lot of differences in terms of their symptoms that they have after the injury. So there have been a lot of different studies trying to say, like, you had a blast versus a non-blast, like, are you, having a different sort of recovery or different symptoms? And in general, they haven't found a big difference. One thing, though, that they did find is that if you had a blast injury, you were obviously much more likely to have sustained other types of injuries along with that more polytrauma. So for the pathophysiology of blasts, there's different levels that you can think about. So primary is when you have that initial blast wave, and that's related to the actual pressure changes from the blast itself. And then secondary is where some object, debris, shrapnel, something from the blast like hits the service member. And then tertiary is where the service member gets thrown against something else, either the wall or the ground. And then quaternary are all the other things that are kind of happening at the same time or a little bit later: heat, light, toxic fumes. This is a picture just sort of describing or depicting the primary blast forces. The x-axis is time, the y-axis is pressure. And so with a blast injury, it's basically where you have the instantaneous conversion of a solid or a liquid into a gas. And so for a moment, it's occupying the same space, same volume. And so it's under extreme pressure, and that builds out. And so that's that initial peak phase there. And then as the gas expands over that larger volume, of course, the pressure will fall. And it falls so much that it also creates a vacuum and kind of a reversal of the forces in the blast wave. And then it sort of oscillates until it equilibrates. So it's not just like one thing and it's done. It kind of, is this whole cascade. It's pretty easy to understand how secondary, tertiary forces can damage the brain. It's your more traditional, like, closed or penetrating injury. But there is not much that we know about primary forces in the brain. And it's probably because it's really hard to isolate people that just had primary blast forces and not secondary and all those other things. So there's a lot that we're still trying to learn about it. There have been a lot of different animal studies where they can artificially create the situation and expose animals to just primary blast forces and nothing else. And when they examine the brains of these mice, they do see that there is a lot of damage. So it is kind of showing that, yes, primary blast forces certainly can have an effect on the brain. There have been a number of different sort of mechanisms. They've seen everything from hemorrhage, vascular injury, vascular congestion, and even DAI type patterns with just primary blast forces. So this study is something that I wanted to talk about because it's one of the few studies looking at primary blast forces in humans. And so the second author there, Dr. Hurley, she's the one I did my rotation with as a fellow. She's actually a psychiatrist by training, but she's taken a special interest in TBI for many, many years. And Her clinic is just TBI. She's very involved in education and research. Her clinic was very fascinating. I'll talk about some of the patients I saw with her. And so I just wanted to share this article with you guys. It's very technical, very physics heavy, so just kind of bear with me because I just wanted to show kind of the big take-home points from it. But they looked at about 40 people who were in OIF, OEF, and there were 3 main groups. So the first group were people who were exposed to a blast and then diagnosed with a TBI or had TBI symptoms. The second group were people who were exposed to blast but no TBI. And then there was a third control group where they weren't exposed to blast at all. And so they did MRIs on all these people and they tried to see, are there white matter changes whether you were exposed to a blast or not. On the MRI, they specifically looked at the diffuser tensor imaging sequence, which is very similar to DWI. It's sensitive to the diffusion of water. And so the idea is that white matter, if it's healthy, it's all those axons, right? It's going to be flowing in the same direction. It's going to have high directionality. And the outcome measure that they use is something called fractional anisotropy. So basically higher FA means more directionality, healthier white matter. Lower FA means not as healthy, that's kind of going all over the place. So they were trying to see if there were measurable changes between these 3 groups. So this first slide, it looks like one brain, but it's actually an aggregate of 2 different groups. And it was kind of their preliminary way of looking at the data. And I'm not going to spend too much time on this slide because they basically found that it is really reliant, this method, the way that they looked at it is reliant on the damage being in the exact same spot for every person, which is not what they expected it to be for primary blast force. So they did this prelim sort of run, and then they basically said, we need to have a different approach that's not so dependent on it all being in the same location. So that's this way. And so the different colors are the 3 different groups. And again, they're measuring FA changes. And so that y-axis there is, you know, the amount of reduced FA. And so the pink group, the one who are blast exposed and had a TBI, they're the ones that are having the most changes in their FA, so the least healthy white matter, followed by the green group and then the blue group. So the pink and the green, as you can see, are much higher and separated than the blue. And the pink and the green, they actually kind of overlap with each other. They weren't actually significantly different from each other.
I don't understand the difference between the 3 groups. Can you talk a bit more about
Between the 3 colors,
blast, TBI, blast?
Yep. So blast TBI are people who were exposed to a blast and then diagnosed with a TBI, had TBI symptoms. And then the green group, they were blast exposed, but they said, I never had a TBI, no symptoms, no post-concussive symptoms. And so they were just exposed to a blast. And then the blue group are people no blast at all. Does that answer the question? Okay. It is, like I said, it's a very technical kind of confusing study, and then it gets into voxels and FA and all that stuff. But so those are the 3 groups that they were looking at, and again, trying to see the white matter changes between them. And so they found that there were significantly more reductions in FA, much less healthy white matter in both the pink and green groups compared to the blue. But the pink and green actually looked pretty similar to each other. So even though one group was not diagnosed with a TBI, they kind of looked like the people who were diagnosed with one. That was kind of their main finding there. And then this slide, I don't know if you guys can even see, it's just kind of showing the spatial heterogeneity of where those different FA changes were. And if you can't see, it's all over the brain. So that's why that first method of looking at the data didn't really work with looking at the delta, because it really required the changes to be in the same spot. So the main take-home message of this paper was that there are measurable changes in white matter in these people who were exposed to blasts compared to those who were not. And interestingly, even if you didn't have a diagnosis of TBI, they actually found pretty similar white matter changes. So they're thinking, even if you're exposed to a blast and you never have any symptoms, there might be something still going on inside the brain at that level. Obviously, there's lots of limitations to this study. It's a small study. A lot of it's reliant on self-report. Like, how do we know for sure that these veterans who said that they only had a primary blast force really only had a primary blast. So it's nothing definitive, but again, I just wanted to share it because it is interesting. It's one of the very few studies that we have looking at white matter changes and sort of indicating that, yes, those primary blast forces probably can cause some damage, even though we don't fully understand everything about it. Okay, so now I'm moving away from blast injury, just talking very briefly about some of the other like injury types that can affect TBI and kind of recovery. So one big topic of interest is toxin exposure. Service members are exposed to all sorts of things, fumes, smoke, burn pits, all of that. And during the Gulf War, actually, there was a lot more interest in, how did these toxins kind of affect the veterans? There's a lot we don't know about it. We don't really understand the pathophysiology. So it is really hard to say for sure what the association is if you don't understand how the damage is occurring. But the VA collects this information. They're trying to learn more about it. And there have been a number of studies that have been shown to be in connection with toxin exposures. A lot of them obviously are going to be respiratory conditions, but a lot of them are sleep, mood disorders, some cognitive disorders as well. And so that obviously is going to have overlap with our brain injury patients if they had an actual TBI and then also are exposed to all these toxins simultaneously or throughout their time in service. Penetrating injury, very similar to penetrating civilian injury. They have much higher mortality rates, and not all penetrating injuries are the same, right? Larger objects, faster objects, objects that cross midline are going to cause more damage compared to those that don't have those things. And there's an interesting effect also called the cavitation effect, which is pretty similar to like primary blast injury, where when an object is speeding through so fast, there are other forces that come out and expand and collapse each time it's going through, causing additional damage. So penetrating injuries obviously can be very serious and have high mortality rates. And then finally, I'll just mention polytrauma. As I mentioned, a lot of people with blast injuries also have injuries to other parts of their body. Fortunately, there's been a lot of improvement in armor and helmets that have led overall to a reduction in polytrauma, but it still happens. As it relates to brain injury, we think about anything that causes hypotension, anemia, that's bad for your brain injury, right? And the immediate care after it. And so anything that leads to hemorrhagic shock, traumatic limb amputation, that's going to have a lot of implications for that person's TBI and how they recover. And then also a lot of face and eye injuries occur at the same time, and you lose other senses. And we know that people with dual sensory impairments have much more higher rates of depression and reduced quality of life. So this is all kind of occurring at the same time with these people. These are a few of the patients that I saw with Dr. Hurley. So the one on the left, you can see is missing a big chunk of their temporal lobe. So he was somebody who had a TBI, really bad seizures, couldn't control it with medications. And so they did a temporal lobectomy to control them. And I wasn't there, obviously, for this. I was seeing him several years later, but as it was presented to me, they didn't test for brain dominance before. And they took out his right side, and usually people are left brain, but he was right-brained. So when they took out that portion, he unfortunately lost his verbal memory. And so within a visit, just you can tell his memory was resetting and he wasn't carrying anything forward. The second picture is somebody who had multiple blast injuries. And I don't know if you can really see it, but there are little like punctate hyperintensities that looks pretty similar to DAI. So just kind of showing these are some of the patterns that you can see with blast injury. The third one was also very interesting, as somebody who got hit really hard in the back of his head. I don't think he ever lost consciousness, so I don't know if he really got evaluated at that time, but then he started having all these frontal lobe symptoms, and then they eventually got a scan. As you can see, he's missing some chunks there, and so we think that maybe he got hit so hard that there was a contra coup lesion, and that's how he had that damage. So that was an interesting case. And then the last one is probably the most fascinating. I don't know if anybody's seen anybody with prosopagnosia or face blindness before, but he had a penetrating injury, and it was so specific to his occipital lobe that he lost the ability to recognize faces. So he's functional, physical, he can see, he's driving, he's doing all the things, but he cannot recognize faces. And my attending told me some funny stories about what happened. Like one time he picked up the wrong kid from school, and had questions about that, like, why did that kid get in the car with somebody who wasn't his parent? I don't know. I wasn't there for that. And then one of the first jobs they gave him when he came back was like looking at people's IDs and like matching it. And it's like, this is the worst job you can give somebody with process, but if you don't know it, right? He looks great from the outside. He's doing everything independently. And so Dr. Hurley had to, help him get the job that he could do. So, like I said, her clinic was very fascinating, and it was a really interesting experience to be able to see some of these cases with her. Okay, so next we'll move on to talking about different comorbid conditions, again, focusing on PTSD just because of how significant of an issue it is. So first, I'm talking about just PTSD, like not even with TBI thrown in the mix. And we know that PTSD is going to be more common the more injuries you have. And it's almost like a cumulative effect, like the more injuries you have, it just kind of your risk for it increases exponentially. And we know that PTSD has a lot of negative consequences on your health. I know you guys can't read the table, but it's like all the things that can happen if you have PTSD. So it actually affects your physical health. There's been studies showing that it has more negative cardiovascular outcomes, sleep issues, GI symptoms from PTSD. And then, of course, it affects not just your physical health, but your mental health, your risk for suicide and suicidality, and a lot of social factors. It has predictors for housing and homelessness, employment, your sense of well-being. And so it affects all areas of somebody's life. This was a nice review, just looking at PTSD and a few other conditions in people who were deployed to Iraq and Afghanistan. And they reported prevalence rates. As you can see, they vary quite a bit. So I don't really know how helpful that piece of it is. But one thing that was interesting is that they went into the risk factors for PTSD. And one thing they really sort of drilled home was combat exposure, which makes sense. The more combat you are exposed to, more chances of you developing PTSD. Even though that makes sense, a lot of studies don't actually control for combat exposure. So when people are looking at PTSD and doing all these studies, they're not controlling for relevant factors. It's hard to kind of make sense of data. So that is really the big one just to kind of be aware of. They also found a lot of associations with gender and deployment characteristics. So they found things like whether or not they had confidence in their leader had predictions for PTSD, the support that they had when they were deployed and when they came home, all of those factors, had an implication for their PTSD risk. They found that military characteristics like branch and rank did not have any association with PTSD. And again, it's probably because it's more related to that combat exposure. And unfortunately, less than half of people who express that they need help actually get the services that they need. And again, these are all people that we know about that come to the doctor's office. We're still missing lots of people who aren't able to come or don't come. This is a very gross oversimplification, but these are the main players in PTSD in terms of brain anatomy. And so the amygdala, which is in the bottom right picture there, is really important for fear processing and kind of integrating the different inputs and assigning an emotional or assigning a fear response to it. And then the insula, which is in the top right, very close to amygdala, is involved in kind of assigning an emotional state, and those two structures talk to each other. And then the other main players are the anterior cingulate cortex, which wraps around the corpus callosum. It's very medially located, so very close to everything. And then certain parts of the prefrontal cortex. Those two organs are more involved for mediating the emotional response. And then the hippocampus obviously is very close by as well. And it's involved in memory, obviously. And so there have been studies kind of looking to see whether these structures are over or underactive in PTSD. And there's some variation, but in general, the amygdala, insula, and hippocampus are overactive. It's just, that cycle is going. And usually the anterior cingulate is underactive. So perhaps it's not doing as good of a job at regulating and kind of trying to stop that cycle. And then the prefrontal cortex kind of varied depending on the study that you looked at. These are other pictures just kind of showing how those cycles work. So again, the amygdala and talking to the prefrontal cortex and the cingulate cortex, kind of creating that affect of fear. This middle picture is just really emphasizing the role that the hippocampus plays, because in PTSD, certainly an external stimulus or trigger can cause that cycle to go, but also just a memory, the hippocampus will really just get that cycle going and lead to, PTSD symptoms. And this third picture here is showing how there are other projections to areas such as the brainstem that can actually lead to motor responses. So it's not just this, emotional sort of disease. There are some projections to the brainstem that can lead to things like freezing, or flight or fight responses because of the connections to the amygdala that way. Now we're going to talk about PTSD and TBI together. And again, the rates are going to vary, but one recent review found that about half of people with military TBI also had PTSD. I wouldn't be surprised if it was even higher than that, but that's the number that has been reported. Of course, PTSD is going to be more common in military compared to civilian, but we still see it in our civilian population too. And then within the military, PTSD is more common in TBI compared to those without TBI. And then when we look at mild TBI and concussion, there actually have been studies in the military trying to figure out different risk factors for your development of post-concussive syndrome. And they did all sorts of things, functional imaging, protein levels, none of that mattered, but PTSD was a risk factor for the development and maintenance of post-concussive syndrome. So that can cause a lot of, morbidity and symptoms, months and years from their injury. A question that I get even with the civilian population is how can I have PTSD if I lost consciousness and if I was in PTA, which is a fair question. But most of the research really supports that you certainly can still have PTSD even though you lost consciousness. And there's a few different reasons for that. One is because at the time of the injury, even if you lose consciousness, there's this extreme fear and stress response that still sends signals to your brain. And it's thought that PTSD signaling could change even that early, like at the time of injury. If there's a lot of stress, it's kind of changing the signaling and, rewiring the limbic system that we just reviewed. The other thing that can happen is reconstruction of memories. Like you're in the hospital, your friends and family keep telling you over and over that you're in an accident. Sometimes people see pictures of their car or their self in the hospital. And so you can kind of reconstruct your memories that way. And then certainly there are other aspects, not just the injury itself, that are very traumatizing after a brain injury. So being in the ICU, being in the hospital, I imagine being in PTA is super traumatizing to wake up every day and not know what happened to you and what's going on. So you can certainly still have PTSD from all those other things and not just the injury itself. And then finally, we spent a little bit of time talking about all the structures involved, possibly some damage to those areas, maybe that increases or decreases your risk for the development of PTSD, since those are the areas that are sort of running it. Not surprisingly, we don't really know very much about that, but there have been a few studies trying to see if damage to certain structures of the brain, specifically in that area, can increase or decrease your risk for PTSD. So a couple studies to mention here. There is one study of pediatric TBI that did find if you had damage to those structures there, you were much more likely to meet the criteria for PTSD. Another study looking at Vietnam veterans found something similar, but a little bit of a variance in what they found. They found that those with damage to the hippocampus did demonstrate PTSD, but those with the damage to the amygdala did not. So again, some inconsistency, we don't really know. There's not enough to say definitively, but I would imagine that if these are the areas of the brain that are controlling PTSD, if you have damage there, you might have some more issues depending on the specific part that's damaged. This is something that's not unique to the military population, and I'm not going to spend a lot of time talking about it. I just want to throw it out there so that everybody just knows what this is. Something called trauma-informed care, and it basically is just acknowledging the widespread impact of trauma. Pretty self-explanatory, but I think it's easy to forget that when we're going on doing our day-to-day jobs. But the basis is just understanding that trauma impacts not just patients, but families, healthcare workers. And so a big piece of it is just trying to prevent re-traumatization as much as possible. So again, I'm not going to talk too much about it. I just want to make sure that you guys know that it exists. Now I'll talk a little bit about some of the other comorbidities, just to briefly mention them. These are not going to be a surprise because we see them in our civilian population as well. But as I mentioned, depression, suicidality is a significant issue in veterans and service members. And so there's going to be overlap with the TBI population there. Sleep disturbances are very common after TBI. And then in the military, you have disrupted sleep cycle, maybe military culture of not needing as much sleep. You're doing missions at weird times of the day. And so that's something that is very common in this population. Substance use, we know that there's a risk for that after a brain injury. And specifically, one study looked at people returning from Iraq and Afghanistan, and they found that people with even mild TBI were 2.3 times more likely to report alcohol misuse. And then pain is a big one. This one study here looked at almost 200 patients, and they found that every TBI patient also had pain, 100%. And so it's something that obviously is very common and has a lot of, similar symptoms and overlap, and, can affect your recovery from your brain injury. And a lot of the studies show that pain can increase from time. I know we like to tell people like, it will get better, it gets better with time. It doesn't always, especially in this population. This is a graph just kind of showing the breakdown of how often these things occur together. So as you can see, the very small minority, just 8% only have a TBI, and then 13% have TBI and PTSD, 17% have TBI and pain, and then 62% have all three. So very rarely, less than 10% of the time, are you dealing with somebody who just has a TBI. So this is the video that I wanted to show you guys, but it's, I don't think the sound is going to work. So I'm just going to show you like a couple of the clips, and I'll just sort of narrate through. Yeah, you guys can't hear. So this is somebody who was a patient of Dr. Hurley's and kind of in the Charlotte area, and they did a news story on him. And so he's talking about his story. He was in the Air Force, and he was in a vehicle, and there was an RPG, a grenade that came and hit his vehicle, exploded, and then also hit his leg. So he had a brain injury, he had a blast injury, and then he had polytrauma. And so he's just talking about how all that happens. It shows some clips of the vehicle. And then he talks about after that, he was dealing with depression, with different mood disorders, and a lot of pain. And he said he would go to the doctor and just tell them what happened, and every doctor would give him opioids. And he unfortunately developed a substance use disorder because he had pain and people were just giving him the medications. And so he really turned into a different person. And then he talks about how he turned it around. So he said it was pop culture when like Prince and Michael Jackson died, is what he said. For whatever reason, that made him turn his life around. He got it together. He had a doctor help him with all that. He got resources. He talked about yoga and acupuncture, kind of taking a more holistic approach to it. And he was able to come out of all that stuff. So I know not all of the stories are happy, but I kind of wanted to put this in there because I think a lot of this talk is a little bit sad. So this just kind of shows an example of a real person who had a brain injury, had all these things going on, but then he was able to get the help that he needs. And it's really about this long-term healthcare, right? You can't just see somebody once and that's the end of it. And so this was a very cool story of somebody who was able to get the help that he needs. Let's see if I can close out of this. I don't know. Do you know how I click out? Oh, there we go. Okay. So with the last just kind of few minutes, I'll talk about just some of the studies that have been done over the years. Again, there's been so much research trying to figure out this population and provide better care to them. Lots of different studies. I'm just going to go over 3 of them. So one of them is the Vietnam head injury study. This one's more unique because it's way before 2001, but they have over 1,000 Vietnam veterans who had their TBI between 67 and 70. And they've been collecting all this data. So it's like 50 years of data. They've published like over 80 papers on it. And they've looked at a lot of different things. So they have all their medical records, obviously. They have neuropsychological testing, imaging, genetics, all this stuff. And again, they've had 80 papers come out of it. So I'm not going to talk about all the main findings, but they did focus on some neurosurgical findings because a lot of these people had penetrating head injury. And so there was a lot of interest in cranioplasty timing and trying to figure that out in terms of what time should it be and rates of infection and all of that. And similarly, they also looked a lot at epilepsy because we know that with penetrating injury, you're more likely to have the seizures. That's one of the risk factors. And so they looked at a lot of the other risk factors in this population. And they also did a lot of sort of memory cognitive testing, trying to see over time, how does their injury when they were in the service affect them decades later. So really just a great wealth of information that they've been collecting. The other longitudinal series in OIF and OEF, again, just collecting a lot of data, trying to see what the long-term outcomes of this. And they found a lot of, not surprisingly, depression, anxiety symptoms up to 8 years after. So again, it's not just like, you know, after 6 months you're recovered and you're done. All these things are kind of going on for years after their injury when they're done with a service. They also looked a lot at functional status. So they found like a significant proportion of people with TBI had moderate to severe disability based on the Glasgow outcome scale. And so these are people based on that who don't get back to work, who need some assistance with ADLs. And so they're pretty significantly impaired. They also found, similar to the other studies, that it's not always that things are getting better. A lot of people, even with mild injury, are experiencing cognitive decline years out from their injury. And then the 15-year study is another study in that group of OIF and OEF. And they found that those with TBI and other injuries, you know, were at high risk for post-concussion syndrome. Again, PTSD probably playing a significant role in that. And they also found that half of people with penetrating TBI met the criteria for mild neurocognitive disorder. And they found that processing speed was one of the areas that was most affected. And then they also sort of quantified some of the caregiving, care partner hours, and they found that people were spending a significant amount of time providing care each week to these people. So in summary, deployment alone is associated with a lot of health consequences, both physical and psychological and cognitive. Many injuries in the military involve the head or neck, as much as 50% in the OAF and OEF population. Similar to the civilian population, most of them are going to be mild. Blast injuries are a really unique injury type with a lot of different mechanisms, a lot of different layers. PTSD rates are very, very high, and all of these studies, all of this information I'm giving you really supports the idea that these people need longitudinal specialized care. Again, it's not something where after just a few months you're recovered and you can go on. They really benefit from following in a clinic that understands brain injury and all the other comorbidities that go into it. And these are some of my references, and thank you for listening.